Hi, and welcome to HIT 243. In this course, we will cover many topics related to quality and performance improvement and how it all relates to healthcare. As a health information professional, you will play a vital role in collecting, analyzing, and displaying the data needed to determine if your facility is providing quality healthcare. But what is quality? The term quality can mean different things to different people, and oftentimes it depends upon the circumstances and your perspective. With healthcare, when people go to the doctor or hospital, they typically expect to get better, but of course that does not always happen. The outcome may depend upon the circumstances. It is possible for a patient not to get better even though they received excellent care. But how do we know that the patient received excellent care? In order to make the determination, it is not enough simply to say that we gave excellent care or service. We must measure our performance so we know if what we are doing is working. We also need to monitor it to see if our performance can be improved. Chances are, at some point in your career, you will be involved in some type of performance improvement process. In this module, we will see how historical events contributed to modern performance improvement programs. We will also take a look at how key legislation and laws influenced healthcare quality initiatives and how some individuals and organizations have developed models for us to use in performance improvement activities. People typically expect that their lives will be better than their parents and that their children's lives will be better than theirs. Over the years, products have improved, and we, as consumers, expect that they will keep on getting better. When cell phones were first introduced, the phone pictured on this slide was considered to be state-of-the-art, and the battery allowed for 30 minutes of talk time before it needed to be recharged. You could only use the phone to call someone. You could not text, access the internet, or take a picture. Chances are, today you would expect more from your cell phone. This is also true with healthcare. The healthcare industry is very complex and is highly regulated. However, this has not always been the case. Let's take a look at how the quality of healthcare has evolved over the years to see how we got to where we are now. In the 1700s, when our country was just getting started, most healthcare was provided in the home, and hospitals were not necessarily where people went to get better. The Pennsylvania Hospital was the first hospital for the community and became a model for other community hospitals over the years. By publishing rules and regulations for its physicians and staff in an attempt to standardize care processes, it represented an early attempt at healthcare improvement. Later in the century, states began to require physicians to be licensed to practice medicine. However, obtaining a medical license was much different in the 1700s than it is today. Over the years, other hospitals attempted quality improvement initiatives. Mass General set limitations and later established the first disease and procedure index by classifying patients' dispositions. The index would classify whether the patient was well, relieved, not relieved, or dead at the time of their discharge. Though this does not seem very meaningful by today's standards, it was the first time data was collected on patients to track whether or not their condition improved or not when the patient left the hospital. In the mid-1800s, medical licensing was deemed to be undemocratic, and most states removed the penalty for practicing without a license. The term doctor could be used by anyone who wanted to sell medical services. In most cases, all that was needed was completion of an apprenticeship with someone who was already practicing medicine. Others attended schools that claimed to teach them how to become physicians. However, medical schools at the time did not have an established criteria. In some cases, the only requirement to receive a diploma from a medical school was to pay the fee. Years later, in an effort to lead reform, the American Medical Association broke its ties with the medical colleges and encouraged states to have an independent licensing board. It was during this time that the hospitals in New England organized a general training school for nurses. By the beginning of the 20th century, it became apparent that in order to promote quality medical practice, regulations would be necessary for curriculum and licensure reform. The Carnegie Foundation sponsored an independent review of all medical colleges in the country. Abraham Flexner, an educator from Kentucky, led this review. Between 1906 and 1910, he visited every medical college in the country and reported his findings to the Carnegie Foundation, the American Medical Association, and the Association of American Medical Colleges, in what is now known as the Flexner Report. He noted the following: most applicants lack the basic knowledge of the sciences. There is an unacceptable variation in curricula that existed across the schools. Clinical skills were limited due to the lack of hospital-based training, and there was a huge amount of graduates every year, and most with an unacceptable level of medical expertise. As a result of the Flexner Report, several changes over the next 10 years were made. Changes included: applicants to medical schools must have a bachelor's degree. The medical curriculum must be based in the sciences, and students must receive practical, hospital-based training recommendations. And they also recommended that most of the medical schools in the United States be closed. Though Flexner recommended that most of the medical colleges be closed, only about half of the schools actually closed during this time. By 1920, most of the colleges met rigorous academic standards and were approved by the AAMC. During this time, hospitals also made improvements. The American College of Surgeons established the Hospital Standardization Program. The program published a format set of hospital standards called the Minimum Standards. After World War II, the economy improved and there were a lot of advances in medicine during this time, including therapeutic, diagnostic, surgical technology, and pharmacology developments. The Hill-Burton Act funded the construction of a lot of new hospitals across the United States, and the renewed health insurance industry helped pay for the new healthcare services. Healthcare services became more costly, and not everyone could afford to buy healthcare insurance or to pay for the services themselves, especially the poor and the elderly. In 1965, the United States Congress passed Public Law 89-97. It's an amendment to the Social Security Act of 1935. Public Law 89-97 is better known as Title 18, or Medicare, which established health care insurance to the elderly and disabled, and Title 19, also known as Medicaid, and that provided grants to states to establish medical assistance to the poor, or the low-income families. Further attempts were made to standardize and improve the clinical services provided by hospitals and physicians. In 1972, Medicare required audits to be performed of hospital and physician medical records. Peer review organizations audited the charts to identify physicians with patterns of substandard care and excessive patient costs. These quality assurance efforts were only partially successful and little effect on the mounting cost of the Medicare and Medicaid programs. As a result, utilization review programs were mandated to justify hospital admissions and the level of services that were being provided. We will discuss utilization review programs in a later module. By 1980, it was obvious that Medicaid and Medicare was on its way to becoming the most expensive government project in U.S. history. It also had become clear that increased spending did not automatically mean the patients were receiving quality care. The prospective payment system was established. This is when health information technology and the medical coding field started to really take off. Peer review organizations contracted with the Healthcare Financing Administration, or HCFA, to perform chart reviews. It was also during this time that the Joint Commission on Accreditation of Hospitals, which is a non-profit accrediting body, changed its name to JCAHO, or the Joint Commission on Accreditation to Healthcare Organizations. The organization's name change reflected that they accredited more than just hospitals. As Deming's total quality and management philosophy spread to the United States healthcare, JCAHO incorporated quality improvement in the accreditation process. In 2001, the prospective payment system spread to the outpatient environment. Ambulatory patient classification systems were initiated, or APCs. In 2002, HCFA became the Center of Medicare and Medicaid Services, known as CMS. There were also changes with JCAHO. The Joint Commission implemented the National Patient Safety Goals, and they changed the accreditation survey process in 2005. They began unannounced and tracer surveys. Healthcare facilities no longer scheduled the surveys. They had to be ready at all times. In 2007, JCAHO officially changed their name again. You may hear people in the field still referring to them as JCAHO. However, that is no longer their name. Today, they are simply the Joint Commission. Other important federal requirements over the last few years include the implementation of MSDRGs, the HITECH Act, the Affordable Care Act, and the implementation of ICD-10-CM and ICD-10-PCS, all which have elevated the field of health information management. Documentation, reimbursement methodologies, the electronic health record requirements, and the change to ICD-10 are all directly related to the advancement of quality healthcare and health information technology. This slide lists some of those who have contributed to the advancement of quality and performance improvement in healthcare. Quality in healthcare has improved a great deal over time, but remember, performance improvement is continuous. Before we wrap up this module, I wanted to mention a theorist, Donna Beaton. He recognized that total quality management, a concept developed by Edward Deming, could be applied to healthcare services. For years, TQM was used in the automotive industry. The key to this philosophy is the concept that problems are generally caused by an inefficient or ineffective processes, not necessarily the people. A team approach is needed to improve the way things are done. Those doing the job started to look closely at the processes and then worked on ways to improve them. Later, some individuals in healthcare realized that oftentimes it is the performance of those individuals in the healthcare organization that determine the quality of services. Quality improvement in those cases were named performance improvement initiatives. We touched briefly on some of the topics. Please read your chapter in your textbook carefully for additional information and details.